Assalamualaikum doctors. In this video I am discussing about Addison's disease management. First of all, the differential diagnosis of Addison's adrenal insufficiency. Acute and chronic. Acute is no pigmentations and chronic is pigmentation present. So acute, there is sudden stoppage of steroids, congenital adrenal hyperplasia, trauma, severe hypertension, sepsis, meningococcemia. Chronic is associated with pigmentation like autoimmune Addison, tuberculosis, trauma, pituitary or hypothalamic, intra-abdominal surgery, pituitary or hypothalamic surgery, radiation is abdominal or pituitary, and adrenoleukodystrophy. What is the differential diagnosis of oral pigmentations? Addison, Pearce-Jaghers, drug-induced or oral contraceptives, chemotherapy, doxycycline, and zidovudine. Causes of Addison's disease: autoimmune, post-tuberculous, the most common cause in worldwide. Then infections in HIV, sepsis, adrenal hemorrhage, amyloidosis, post-surgical removal of adrenals, and adrenoleukodystrophy. Okay, so how can we manage Addison's disease case? First of all, I will examine her carefully. Vitals, blood pressure, glucose. Then I will assess the airway, breathing, circulation, and consciousness level, GCS scale. Obtain IV line. Is in shock therapy. If in pain, analgesic. Okay, shock therapy, pain analgesic. I will discuss with my consultant if she needs admission. Anthropometric measurements, plot on the growth chart and check his previous measurements. I will involve my senior and if needed my consultant, I will run some tests. So, investigations are lab by doing full blood count, anemia show, urine electrolyte show low, sodium and bicarbonate, and high potassium and calcium, glucose is low. So, sodium low, glucose low, bicarbonate low, there is anemia present, increase the calcium and the potassium. 24-hour cortisol in urine or early morning cortisol in blood, ACTH level elevated. Plasma renin high, aldosterone level is low. Antibody against the 21 hydroxylase. Then if male is neurological behavioral issue, VLCFA will be high. Diagnostic test is short synecthin test and long synecthin test. And others workup for autoimmune disease, radiotherapy, abdominal CT or ultrasound scan for adrenal gland and X-ray, MRI brain, chest X-ray or CT, ECG for the effect of hyperkalemia. Annual review I do lab, full blood count, urine electrolyte, liver function test, vitamin B12, parathyroid hormone level. Celiac screening, thyroid functions, glucose and HbA1c. Review of the skin. If there is skin thinning or striae, steroid toxicity and search for hyperglycemia and hypertension, steroid overdose. And if pigmented skin, generalized fatigue and weakness, search for hypotension, low glucose or poor compliance. So, investigation I am doing full blood count, urea in electrolyte, creatinine, and I am doing the 24-hour urinary cortisol level, then antibody against 21 hydroxylase, then if neurological and behavior issue in male, VLCFA level, and short synecthin test and long synecthin test. Short synecthin test I am telling you, that is injection of the ACTH, then measure the cortisol level in blood before and after 30 minutes and after 60 minutes. Normally increase cortisol productions. If low cortisol, so Addison. So short synecthin, long synecthin, then annual follow-up, celiac screening, thyroid screening, blood count, then abdominal ultrasound, abdominal CT, MRI brain, and these are also steroid toxicity will search. So what is the treatment I will give? Treatment of Addison's disease is that treatment of adrenal crisis, urgent treatment with IV normal saline, glucose and hydrocortisone. Long-term management with glucocorticoid and mineralocorticoid replacement. Parent and patient educations. Multidisciplinary team, I will involve the endocrinologist, dietitian, gastroenterologist, social worker and support to the family, psychological support and psychiatric if needed, liaise with the school for emergency and for bullying. Advice bracelet, medic alert bracelet or necklace, steroid card, education to the patient and family about the sick day rules. And when the must double the dose, febrile illness, gastroenteritis, major trauma, surgery and endurance sport. Then about education about how to inject IM hydrocortisone in emergency, importance of the treatments and good compliance and follow up. Adrenal crisis symptoms is hypotension, hypoglycemia with fainting attack, hypotension, hypoglycemia with fainting attack, vomiting, abdominal pain and low-grade fever. Treatment are admissions, ABCD, IV hydrocortisone, IV fluid, fluorocortisone. Not in the first year, give salt instead, antibiotics if needed. So treatment is, glucocorticoid and mineralocorticoid supplementation. And if it is acute, like shock developer, then ABCD, IV fluid, then shock therapy, hydrocortisones, we give fluorocortisones. These are. Antibiotic if needed. 6 days rule. What is 6 days rule? If mild, double the dose of hydrocortisone for 24 to 48 hours. If moderate, double the dose, and if vomiting, after 1 hour, start IM injection. If severe illness or collapse, IV hydrocortisone and call ambulance. So this is all about Addison's disease management and the features. Look, they have pigmentation, oral pigmentations. Any trauma surgery, sudden stoppage of steroid, these are, and it's autoimmune cause can be present. So this is all about Addison's disease. Thank you.